Hello, and welcome back to another chapter of Pediatric Primary Care. Today we'll be talking about Chapter 16 Sleep. Sleep has a critical role in the health and well being of infants, children, and adolescents. Essential for growth, development, emotional health, and stability, sleep allows the brain to process emotional and physical experiences that occurred during wakefulness, create long-term memories, encode learning, and provide cycles of physiologic rest, healing, and recovery. Sleep for infants, children, and adolescents occur with a complex psychosocial environmental system in which adults can hinder or support sleep-related behaviors and sleep health. In addition, sleep patterns and the physiologic need for sleep change across the pediatric lifespan. As the scientific understanding of sleep and the role that technology and socioeconomic influences have on sleep continues to evolve, the value of evidence-based assessment interventions and education that promote pediatric sleep health becomes increasingly important. Pediatric primary care providers must prioritize sleep health, consider implications of poor sleep quality, and be prepared to recommend developmentally appropriate anticipatory guidance to parents and later to children and adolescents that promote sleep health. Sleep health has been defined as a multidimensional pattern of sleep-wakefulness adapted to individual, social, and environmental demands that promote physical and mental well-being. Good sleep health is characterized by subjective satisfaction, appropriate timing, adequate duration, high efficacy, and sustained alertness during waking hours. In pediatrics, sleep health is significantly influenced by a complex myriad of socioecologic factors, including proximal factors, such as individual medical conditions, individual temperament, and family parenting styles, and distal factors, such as sleeping arrangements, light and noise in the bedroom, home and neighborhood, school start times, and cultural norms that would influence sleep. A visual representation of socio-ecological factors that influence pediatric sleep health is shown in Figure 16.1. Science of sleep. Pediatric sleep cycles are regulated by both intrinsic factors and extrinsic factors. The circadian rhythm is a genetically determined internal 24-hour sleep-wakefulness cycle influenced by environmental light and darkness. In humans, darkness perceived by a nerve pathway in the retina triggers the supraschematic nucleus in the brain. The SCN then signals the secretion of the hormone melatonin from the pineal gland, which promotes sleepiness. Melatonin secretion diminishes with exposure to daytime light, promoting wakefulness. The circadian rhythm is not well established until after the first months of life. The development of circadian rhythm contributes to nighttime sleep consolidation around 3 months of age. The initial phases of sleep-wake cycles are controlled by the homeostatic sleep pressure, physiologic function, and cortisol secretion. The homeostatic sleep pressure, or drive for sleep, is influenced by periods of daytime alertness, physical energy expenditure, diet and nutritional status, and the child's age and developmental phase. Healthy adults typically require about 16 hours of wakefulness and energy expenditure to build sufficient homeostatic sleep pressure, compared to infants and children who require much fewer wakeful hours to expend enough energy to create sleep pressure, accounting for the need for daytime napping. As children mature, their sleep pressure diminishes, resulting in their ability to remain alert without napping during daytime. After puberty, adolescents gain the ability to delay bedtime through natural growth and changes in their circadian rhythm. Recognizing the factors affecting sleep across the pediatric lifespan helps the primary care provider, recommending strategies that targeted for age and tailored for the individual to promote sleep health, decrease daytime sleep pressure, and increased feelings of alertness and engagement. Extrinsic factors that influence sleep health include social and cultural behaviors and family systems that children often have no control over, including sleep arrangements, such as co sleeping with parents in the family bed, sleep location, family and school schedules, bedtime routines, factors that inhibit sleep health, such as diet, technology use prior to bedtime, and parent child interactions. A critical aspect of assessing sleep health is the routine inquiry about extrinsic factors during well-child visits, evaluation of extrinsic factors, and assessment of the regulatory or regularity of bedtime and wake time is critical. As consistent routines are essential for maintaining healthy sleep rhythm, through consistent anticipatory guidance, the PCP can help families anticipate and prevent problematic sleep-wake cycles that result from predictable and modifiable factors, including diet, technology usage, and varied bedtime routines among weekdays, weekends, and holidays. Sleep cycle. Although peaceful slumber is a phrase often envisioned while an infant or child sleeps, this psychologic process is quite dynamic, consistent of cycles that repeat every 90 to 120 minutes throughout the night. Each cycle has measurable phases of neurologic activity and is important to the overall process of healthy sleep. In each cycle, there are two phases of sleep: rapid eye movement or REM and non-REM or NREM. The NREM sleep is the primary phase of sleep, occurring most of the sleep cycle time. It has three subphases, labeled 1 through 3, that are identifiable by subtle physiologic and electroencephalographic patterns. Typical order for each sleep cycle is N1, 2, 3, and REM, although a greater amount of time is spent in deep sleep, which is considered N3. Earlier in the night, whereas the amount of REM sleep increases in the last two cycles, just before natural awakening. So here we're going to stop for a moment and hit pause so you can look at figure 16.1, the socioecological factors hypothesized to contribute to pediatric sleep health domains. And then we'll also take a quick peek at figure 16.2, which has the different sleep stages. The REM, which is again the rapid eye movement, and the SWS, or slow wave sleep. So if you're unfamiliar, here's a good time to pause and review. Speaking on NREM Phase 1. Phase 1 is a period of drowsiness that occurs during early transition to sleep. Aside from newborns and children diagnosed with narcolepsy, the average child's sleep stage begins in N1 sleep. It includes slowing body movements, eye rolling, jerky or twitchy body movements, and fluttering eyelids. Individuals may even believe they are awake, but they cannot accurately report events that occurred during this time. The first phase of sleep provides the body with musculoskeletal recovery from physical activity and energy expenditure during the day, bringing us to the Phase 2. NREM Phase 2, or N2, is a deeper sleep state in which eye movements, breathing, and heart rate slow and the distal extremities cool. Muscles slacken, although children in N2 are able to reposition their bodies or arouse. Bringing us to NREM Phase 3, or N3, also known as deep, delta, or slow wave sleep. During this stage of sleep, a child is sleeping soundly and difficult to awaken. During N3, sleep occurs in longer periods, earlier in the night, particularly during the first two sleep cycles. It is during N3 that growth hormone is released. It is also when parents note sleep walking and talking, bedwetting, and night terrors. Which finally brings us to REM sleep. REM sleep is a time of psychological recovery and consolidation of memory and learning from the experiences of the day. It is characterized by increased brainwave activity, dreams and nightmares, and active eye movements that resemble an awakened state. While experiencing vivid dreams or nightmares, the muscles are slack, which protect the individual from physically acting out their dreams. REM sleep is considered a time for the brain to learn from the experiences of the day. The proportion of REM sleep is highest during infancy, but gradually decreases by 5 years of age. Each phase of sleep is so critical to growth, development, and psychological well-being that when children are deprived of the specific sleep phase, particularly REM or N3, pressure to restore it will mount. A rebound pattern develops in the effort to gain homeostasis, with the body shortening over phases to regain the stages that have been lacking. Discrepancies or imbalances in sleep cycles also affect behavior, mood, and daytime function. Those deprived from REM sleep become excitable, irritable, and anxious, while those deprived of N3 sleep experience intense fatigue. Individuals typically have brief arousal between sleep cycles. Most are so brief that they cannot be recalled. However, the brief arousals between cycles in young children may sometimes be misinterpreted by parents and adult caregivers as awakenings that require social engagement or late-night feedings, resulting in altered sleeping arrangements and dysregulated sleep for the entire family. Which brings us to Table 16.1, the pediatric sleep requirements. Again, if you're unfamiliar, go ahead and hit pause to review. Sleep patterns. Homeostatic sleep demands changes as a child matures, including sleep needs, duration, and cycling. Though individual sleep patterns vary due to instinct and extrinsic factors, the average hours of sleep required for each 24-hour period is well established and can be useful for primary care providers when providing anticipatory guidance. Developmental sleep considerations. Speaking strictly now to newborns and infants. Newborns sleep anywhere between 14 to 17 hours per day, while infants require only 12 to 16 hours. Newborns and young infants, those 6 months and younger, spend 50% of their sleep time in active REM sleep, which gradually decreases to 20 to 25% of sleep time in adults. REM sleep is often evident in newborns with audible suckling, smiling, twitching of arms and legs during sleep. The active REM sleep of infants results in shorter sleep cycles and more frequent arousal. Their cycles can last a few minutes to several hours in the first weeks of life. Once the circadian rhythm is established, typically by 3 to 4 months, most infants sleep through the night without needing for feeding, while newborn sleep occur on an irregular schedule with periods of 1 to 3 hours spent awake. Sudden unexpected infant death. Sudden unexpected infant death, or SUID, is an umbrella term used to describe any sudden and unexpected death of an infant, 0 to 12 months of age, explained or unexplained, occurring in the first year of life. SUID includes infant death from suffocation or asphyxia, entrapment, infection, ingestions, metabolic disease, arrhythmias, and unintentional or non-accidental trauma. Sudden infant death syndrome, or SIDS, is a subcategory of SUID, accounting for about half of all SUID cases. It is defined as a death of an infant that is unexplained after a thorough case investigation, which includes autopsy, a scene investigation, and clinical history analysis. The pathophysiology of SIDS is multifactorial, with the triple risk model being the most widely accepted lens for understanding. This model proposes that SIDS occurs when an infant with intrinsic vulnerability experiences an exogenous stress factor during a vulnerable period of development. Of note, the risk for SIDS is not linked to infants who have experienced brief, resolved unexplained events that are witnessed. Infant sleep-related deaths have declined since the American Academy of Pediatrics' Back to Sleep campaign began in 1994. However, SIDS continues to be the leading cause of post-neonatal deaths in infancy. Of note, however, is that infant sleep-related deaths data show notable and persistent racial and ethnic disparities that reflect ongoing racial and ethnic societal inequities and health outcomes among populations. Mortality rates for white infants have declined faster when compared to rates in non-Hispanic Black and American Indian Alaskan Native infants. Low socioeconomic status, unemployment, housing instability, and domestic violence are correlated with higher risk of sleep-related deaths. Currently, the occurrence of SIDS remains greater than 3,000 deaths per year in the United States, with most occurring before 6 months of age. SIDS deaths are higher among males, those born prematurely or small for gestational age, and among infants with mothers who are less than 20 years of age. While the actual mechanism for SIDS remain unclear, there are strategies that reduce the risk of SIDS among infants, bringing attention to modifiable factors. For example, infants who co-sleep or share sleep space in a bed, couch, or chair with adults, especially in an overly warm environment and in soft bedding, that are highest risk for SIDS. This knowledge gave rise to the Safe to Sleep campaign, which focuses on multiple ways other than infant position to reduce the risk of SIDS and other sleep-related causes of infant death. In 2022, the AAP updated the 2016 SIDS prevention recommendations, enhancing safety recommendations that reduce risk of infant sleep-related mortality. These recommendations also include a call for pediatric PCPs to offer anticipatory guidance to each new parent and serve as pediatric advocates engaged in policy and industry safety recommendations. Which brings us to early childhood. The number of hours spent sleeping continues to decrease. However, longer hours are spent sleeping at night, supplemented with 2 daytime naps. Children between ages 1 to 2 old require 11 to 14 hours of sleep per day, while those aged 3 to 5 require 10 to 13 hours. Again, take a look at that table 16.1. Sleep difficulties such as resisting going to bed and nighttime awakenings are common in children 1 to 2 years of age as part of their seeking independence, paired with increased motor, social, and cognitive abilities. Separation anxiety begins in infancy but can extend to up to 2 years of age, which can contribute to resistance at bedtime. Fears and nightmares are also common in this age group, especially after age 3. Children ages 3 to 5 years often have difficulty with sleep latency or falling asleep. Waking up during the night is also common in this age group. As their daytime imaginations evolve, so do their nighttime fears and nightmares. In addition, somnambulism or sleepwalking and night terrors are at their peak, both of which are typically alleviated by ensuring regular daytime routines and sleep patterns. The American Academy of Sleep Medicine, or AASM, guidelines for managing sleep disruption in early childhood primarily focus on behavioral therapies, including gradual removal of the parental presence, positive bedtime routines, and scheduled daytime awakenings as effective therapy. Which brings us to box 16.1, major protective factors against sudden infant death syndrome or SIDS. Again, a good spot to hit pause if you're unfamiliar. Middle childhood. Sleep requirements have decreased to 9 to 12 hours a day for this age group. Naps are now gone, sleep disturbances are common, especially when starting school as they adjust to academic routines. Sleep deficiencies are predictive of cognitive, behavioral, emotional, and academic outcomes. Studies show that 5 to 6-year-olds with shorter sleep duration or difficulty settling or staying asleep at night score significantly lower on IQ and other achievement tests, and children who regularly sleep 10 or more hours in the 24-hour period have better social adjustment to academic routines, social and academic demands, and extracurricular activities also increase during this age. Further, many schools now use computers in the classroom, and children also often engage in other screen time activities, with blue light, which can affect the child's normal circadian rhythm by fooling the body that it is still light out. Healthy sleep hygiene, which includes an organized, consistent routine bedtime, limited screen access, especially an hour before bedtime, and avoiding caffeine and sugar after the dinner meal or 4 to 6 hours before sleep initiation, is critical for well-being of children. Bringing us to adolescence. Up to two-thirds of adolescents in the US get less than the recommended 8 to 10 hours of sleep per night. They also experience the most sleep disturbances of all pediatric age groups. About 1 in 4 teens report sleep delay, nighttime awakening, and feeling sleepy during the day. The rate nearly doubled during the SARS or COVID-19 pandemic, which was mostly attributed to remote learning environments, social isolation, limited outdoor and in-person activities, and poor sleep hygiene. These sleep disturbances have resulted in academic progression delays and increased rates of mental health disorders, especially anxiety, depression, and suicidal thoughts, coupled with adolescent risk for sleep disruption. Many had less sleep than recommended for healthy growth and neurocognitive development. There is a natural circadian shift that occurs around puberty, as circadian rhythm moves forward approximately 2 hours. This shift makes it difficult to fall asleep earlier in the evening and difficult to be awake for the typical early school start times. Even after a call from the AAP to move start time later than 8:30 a.m., most middle and high schools continue to have early start times. Pubertal circadian rhythm changes and sleep cycle, along with a mismatch of school start times, often result in chronic sleep deprivation among many adolescents. Additional risks include social and school activities that involve screen time technology, after school activities, employment, homework, and athletic or social obligations, as each contributes to delayed sleep initiation. Many teens report daytime sleepiness, napping, and oversleeping on weekends and school holidays to make up their sleep debt from the week. Unfortunately, physical and mental health safety and academic outcomes are linked to poor sleep and may have lifelong implications, as adolescents who consistently sleep less than 8 hours a day are more likely to experience greater levels of anxiety, irritability, and other somatic and psychologic symptoms. The result of chronic sleep deprivation and attempts to catch up on weekends are also linked to disordered eating, weight gain, hypertension, and abnormal glucose metabolism, all of which have metabolic and cardiovascular implications that extend into adulthood. Healthy sleep hygiene emphasizes adhering to a routine sleep schedule, eliminating evening caffeine use, turning off blue light emitting devices at least 1 hour before sleep, promoting exercise during the day and limiting adolescent school, work, and after school schedules to ensure adequate rest and sleep habits. There is also evidence to show consistent family meal times occurring even twice a week have a protective effect that contributes to healthy sleep among adolescents. Family mealtimes promote engagement and offer adolescents opportunity to focus on positive events, attributes, and emotion that occur. Another important role of family meals and engagement is the opportunity to help adolescents gain insight from the information gleaned in their technology and media usage, and foster a family commitment to implement agreed upon boundaries for technology usage. Pediatric sleep experts recommend initiating strategies that promote sleep before adolescence, if possible, reiterated during routine adolescent clinical visits, modeled in the home through family engagement, and reinforced in academic settings through education, peer support campaigns, and media reminder. The AAP, AASM, and the CDC and prevention offers sleep strategies and toolkits for PCPs and families, which we'll see more in the additional resource section. Impact of digital technology. Adolescents are increasingly using digital resources and technology, not only in school for learning, but also to play, entertain, and communicate with each other. This increase in screen time and exposure to blue light has health implications directly related to sleep deprivation. Furthermore, the World Health Organization officially recognizes digital technology data in 2020 and identified that digital technology and devices are readily available to most adolescents, placing them at increased risk for addictive behavior. The DTA is described as excessive online activity and internet use, resulting in inability to manage time, energy, and attention during daytime and disturbed sleep patterns or insomnia during nighttime, and has significant implications for adolescent brain development and long term health outcomes. The DTA has been further classified as Internet Addiction Disorder or Internet Gaming Addiction, characterized as uncontrolled Internet use and defined by behaviors that include gaming or Internet use for long, uninterrupted time periods, skipping school to play, withdrawal from other social activities to use the Internet, resorting to gaming or Internet to avoid emotions, and consequentially sleep problems. While the DTA has been significantly linked to depression and insomnia, studies show that general non addictive use of the digital technology is also linked to mental health conditions, including anxiety, isolation, depression, disordered eating, self harm, substance use disorder, and suicide, all of which have a direct relationship to sleep disruption. Since the use of technology is not likely to diminish in the future, it is critically important for PCPs to educate and empower adolescents and parents with strategies to combat digital technology addiction and ensure adequate sleep. Assessment of sleep. Sleep is vital to growth, development, well being, and long term health outcomes across the pediatric lifespan. Routine assessment of sleep should occur alongside nutrition, safety, activity, and family relationship assessments. The National Sleep Foundation advocates that sleep be considered a vital sign, particularly among adolescents who are notoriously sleep deprived. Routine screening of sleep at each well child visit should include asking the parents broad generalized inquiries, including: tell me about your child's sleep. Does your child have any sleep problems? And is there anything you wish to change about your child's sleep? The PCP should also assess the environment where the child sleeps, the bedtime routine, and if the child snores or experiences other sleep disruptions. It can be challenging in young children who are unable to offer a description of their rest, so PCPs must rely on adult caregivers for accurate history. Once children are old enough, it is important to note any differences between the data from the child versus the parent. Parents are often unaware of sleep difficulties, disruptions, or daytime sleepiness in older children and adolescents. Any sleep concerns should be evaluated using a standardized approach, including detailed history, physical exam, and, if warranted, special testing or referral to a pediatric sleep specialist. Bringing us to the history. The chief complaint. Evaluation of sleep concerns or problems involves a comprehensive history of the child's 24-hour routine, focusing on bedtime habits, sleep environment, and daytime behavior. The family, medical history, and parental attitudes and beliefs about what constitutes normal sleep are also important and can inform the investigation and treatment plan. When sleep difficulties are noted, it's important to conduct a symptom analysis, asking about the age when the problem began, precipitating events, presence of symptoms on the weekends, holidays, or vacations, and if aggravating or alleviating factors are present. It is also important to assess its effects on the child or adolescent daily functioning, as well as the impact on other family members. Past medical history and the review of the systems. Medical problems are often associated with sleep difficulties, including any associated pain and discomfort. Other areas to assess would include obesity, neurologic disorders, respiratory conditions, GI reflux, nocturnal enuresis, dermatologic conditions, pulmonary hypertension, failure to thrive, developmental delays, epilepsy, and depression, anxiety, or other types of psychiatric problems. Family history, parental knowledge and expectations about typical sleep patterns, parental ability and willingness to modify sleep hygiene. Family history of sleep disorders includes sleep apnea, obesity, substance use, neurodevelopmental or mental health conditions, recent divorce, separation, family or close friend death, changes in living or school arrangements, other family stressors, or exposure to trauma, violence, or a natural disaster. Physical examination. A thorough and complete physical examination is indicated for individuals with sleep issues. Vital signs should be obtained, including the occipito-frontal circumference for infants, pulse oximetry, weight and length and height, body mass index, blood pressure, and pain assessment. Adolescents should also be screened for depression using the standardized screening tool. Neurologic evaluation, including the child's muscle tone, range of motion, strength, and gait, should also be completed. Special attention should be paid to obvious tone and strength discrepancies, unstable gait, hyperactivity, rapid speech, jittery or anxious appearance, and symptoms of depression, including self-injury, bruising, or scars. It's important to assess for dermatologic conditions, which would include hives, eczema, rashes, acne, and enlarged or multiple hyperpigmented macules that could signal an underlying condition or could be contributing to the sleep concern. Careful assessment of sinuses, nose, mouth, and throat, as well as the neck, are also important when assessing the risk of snoring. Clinicians may note cough, loud breathing, frequent sniffling or sneezing, clearing of the throat, swollen nasal turbinates, dull and or painful sinuses, a raspy, congested voice or cry of the child with chronic allergic rhinitis, severe asthma, and or a narrow airway. Findings in children at risk for sleep-related breathing problems may also include a deviated nasal septum, nasal polyps, open mouth posture, high arched palate, adenoid facies, enlarged tonsils, narrow oropharynx, low-hanging soft palate, and micro or retrognathia. So, that brings us to our standardized screening tools. Sleep assessment tools and questionnaires, which will be listed in Table 16.2, are used to assess the various aspects of sleep domains, including sleep satisfaction, timing, efficacy, duration, and behavior. However, these tools only self-report by either the parent and or or the patient. They do not include behaviors observed outside of the home, which may limit an accurate assessment of sleep efficacy and daytime alertness. One tool, the Pediatric Sleep Practice Questionnaire, can be used in screening for sleep issues in children 8 to 17. It features questions that include assessment of technology use before bedtime and the sleep environment, which have been identified as significant contributors to sleep quality of older children and teens. Importantly, it includes only 15 items, making it useful in busy practices, while still providing the PCP with insight into conditions that impact sleep quality. The findings provide a baseline from which to provide guidance, education, and direct discussion with children, adolescents, and their parents to enhance sleep practices. Referral and special testing. Pediatric sleep specialists typically use an interprofessional approach and often collaborate with pediatric developmental specialists, genetics counselors, developmental pediatricians, neurologists, and ENT specialists when children have specific medical conditions. Sleep specialists commonly order a polysomnogram, a multiparametric test that reports total sleep time, sleep latency, and sleep efficacy. Another test is the actigram, which measures light exposure and activity, typically over 1 week in the child's home environment via a device that the child wears like a wristwatch. It is helpful for evaluating the effectiveness of insomnia treatments, since the total sleep time is measured throughout the test. Results offer an objective measurement for children and parents that can dispel sleep misperceptions about length of sleep and the environment that is conducive for quality sleep. An example would include adolescents who report being awake most of the night, gain valuable data on the true length of time they sleep, which can allay concerns about a chronic condition, and offer evidence of sleep hygiene. The test also offers clinicians with the opportunity to promote or reinforce additional sleep promoting practices. The PSG is less invasive and less expensive than actigraphy. Other testing may be considered depending on the preventing condition, medical history, and exam findings. Common sleep-related disorders. The most common sleep-related disorder in childhood is behavioral insomnia, affecting about 10 to 30% of young children. It often results from inconsistent parental limit setting or inconsistent sleep onset. Other pediatric sleep-related concerns would include restless leg syndrome and periodic limb movements, parasomnias, SDB, OSA, and central sleep apnea. Children with neurodevelopmental disorders such as ASD and ADHD have the highest rates of sleep disorders during childhood. Insomnia in children is defined as sleep onset delay more than 30 minutes per night and or frequent prolonged night awakening with impaired daytime functioning. A variety of medications may be considered for insomnia. Melatonin, available over the counter, is commonly recommended, though there are currently no treatment guidelines for pediatric dosing. However, it is associated with improved sleep quality among children without significant risk factors or associated side effects. Antihistamines, which would include diphenhydramine and hydroxyzine, are the most widely prescribed short-acting sedatives in pediatrics, but limited evidence exists to support their use. Guanfacine, an alpha-2 adrenergic agonist, has also been successfully used to promote sleep onset. There is limited evidence to support the use of an alpha agonist, such as clonidine, to improve sleep latency, especially in children with ADHD. Restless leg syndrome and periodic limb movements. RLS is a sensory motor disorder characterized by irritating sensations in the legs accompanied by an irresistible urge to move the legs, which typically helps. There is an association of RLS and ADHD, which may not be evident to children and parents until after ADHD treatments have been initiated. PLMS are repetitive jerks, typically in the legs, that occur every 5 to 90 seconds. RLS and PLM usually occur together, but PLMs may occur without RLS. The prevalence of PLMs in school-aged children has been estimated to 1.9 to 3.6%. However, the condition is often unrecognized in younger children or those with delays secondary to communication deficits. The etiology of PLMs remains unclear, but genetic factors, dopaminergic dysfunction, low iron storage status, and side effects of selective serotonin reuptake inhibitors, sedating antihistamines, and dopamine receptors antagonists have been implicated. Children with RLS and PLMs typically have a history of abruptly awakening during the night following 1 to 3 hours of sleep. Upon awaking, affected children cry, kick, and strike their legs, verbally expressing that their legs hurt. The discomfort is often relieved by massage or stretching. Other significant history also includes daytime sleepiness and/or hyperactivity and insomnia. Children with RLS often have a normal physical and neurologic exam. Serum ferritin levels are indicated to rule out iron deficiency anemia, which is associated with RLS. Treatment is typically correction of iron deficiency with oral supplementation of ferrous sulfate and removal of any other triggers. Other conditions to rule out include leg cramps and Osgood-Schlatter disease. Parasomnias. Again, NREM parasomnias include confusional arousals, somnambulism, and night terrors. Precipitating factors include sleep deprivation, stress or emotional upset, febrile illnesses, being overheated at night, a full bladder, or use of central nervous system depressant medications, which would include diphenhydramine or Benadryl. These factors interrupt deep sleep, causing partial awakening, which results in disorientation or fear in young children that they may not recall the following morning. Confusional arousals typically occur in early childhood and diminish around the age of 5. Often frightening to the adult caregivers, the child awakes from deep sleep early in the sleep cycle night, appears dazed, and is slow to react. It is described as excessive sleep inertia or sleep drunkenness or somnambulism, which occurs in approximately 1 to 15% of children and can pose a safety threat. It begins as confusional arousal characteristics by a dazed expression with open eyes and mumbled or slurred speech, while they briefly wander or even run around their bedroom or home. In REM, confusional arousal are typically short-lived and benign in young children, and best managed by not awakening the child while ensuring safety, especially in a home with stairways. Some parasomnias can be prevented by identifying the stressor, ensuring adequate nap times, controlling the sleep environment, and resolving febrile illness. Night terrors. Reported in about 5% of children ages 18 months to 6 years are an extreme state of agitation, characterized by a sudden onset of screaming, dilated pupils, increased heart rate, and sweating during N3 sleep. Nightmares are distinct from night terrors, and they occur during REM sleep, during the last sleep cycle of the night. They occur in about 25% of all children 3 to 6 years of age, characterized by a sudden arousal from sleep to fully awake state. Nightmare details are often recalled in the next day, whereas night terrors are usually not remembered. Occasional nightmares occur throughout life and are more common during times of stress or situational changes. Parental reassurance is generally effective. Assessment of parasomnias includes a careful history of the event, physical exam, and testing for febrile illness or recurring nocturnal enuresis, which is reported. Assessment of parasomnia concerns should include historical data of the event in relation to sleep onset, frequency, and length of the episode, evidence of the apnea or limb movements, temperature of the sleeping environment, and sweating history. Family history would include consideration of sleepwalking, medications or supplemental usage, typical sleep patterns and routines of the child and family, stressors in the environment, including change in school, environment, new siblings, or parental relationships, and the child's memory of the event. Recurrent nightmares warrant investigation by the healthcare provider, including a careful history and physical exam. So we're going to go back up because we skipped over a chart here. And this would be the Pediatric Sleep Health Questionnaire and Measures. Again, here's an excellent spot to hit pause to review. Sleep disordered breathing and obstructive sleep apnea. Children with SDB can present with simple snoring, upper airway resistance, and even OSA. Snoring occurs in as many as 17% in children. However, OSA is found in 1 to 5% of infants and children. Untreated OSA can result in various physical problems, including obesity, metabolic disorders, hypertension, and cardiovascular insult, all of which have lifelong implications. OSA is strongly associated with insufficient sleep, which in turn can result in mental health, social issues, and poor academic performance. Risk factors include tonsillar or adenoid hypertrophy, obesity, craniofacial abnormalities, gastroesophageal reflux, neuromuscular disorders, and untreated allergic rhinitis. Children with neuromuscular disorders might not snore, but should still be evaluated for SDB. Both SDB and OSA include snoring, gasping, apnea events, increased work of breathing with paradoxical respirations, neck hyperextension, night sweating, tachycardia, or restless or disrupted sleep. With SDB, persistent parasomnias and history of insomnia are common. Typically, the child arouses during significant snoring or gasping after an apneic episode, then resumes sleep until another episode occurs during the night. A careful history and physical exam will help distinguish snoring from OSA. A pediatric sleep specialist evaluation and positive PSG are typically involved to confirm OSA. Polysomnography identifies the severity of the OSA, provides data to plan for pre and post-operative care, and offers a baseline for comparison in the post-operative sleep study. Adenotonsillectomy is the first-line treatment for OSA. Other surgical options include partial tonsillectomy, craniofacial surgery, and tracheostomy in severe cases. Additional procedures for the management of OSA may include tongue-based reduction surgery, uvulopalatopharyngoplasty, lingual tonsillectomy, supraglottoplasty, and hypoglossal nerve stimulation. Surgery is only for children who have tonsillar or adenoid hypertrophy, and those who are young age or have morbid obesity or family and other health risk factors. Surgery may be contraindicated. For these children, nasal continuous positive airway pressure or CPAP may be considered as a second-line treatment. Other non-surgical options may be effective for managing child's mild to moderate OSA, including nasal steroids and leukotriene receptor antagonists, normal saline rinses, and weight loss. Nasal steroids and montelukast can be effective in mild to moderate OSA by reducing the lymphoid tissue, especially the adenoids. CPAP provides humidified air pressure via nasal mask without supplemental oxygen. For STB treatment, occasionally a child with neuromuscular disorders requires extra support with tidal volume, oxygen, high pressure, or backup respiratory rate. Many children and adolescents do not tolerate or adhere to CPAP treatment, so other treatment alternatives such as a positional therapy, high-flow nasal cannula, and the use of orthodontic procedures such as a rapid maxillary expansion and mandibular advancement devices ought to be considered. Central sleep apnea. Central sleep apnea is a pathologic form of apnea that is rare in children. It typically indicates a significant neurologic condition, such as a brainstem lesion, Chiari malformations, or exposure to narcotics that diminish the respiratory drive. Children with CSA have no arousal, snoring, or gasping. The apnea episode frequently results in oxygen desaturation and risk of cardiovascular arrest. Treatment is immediate, ventilator support, and oxygen via while determining and correcting the underlying cause. CSA occurs among extreme premature infants who can eventually outgrow apneic events as they mature, with careful monitoring and support. Sleep concerns with neurodevelopmental and mental health disorders. So, the autism spectrum disorder. Children with ASD commonly experience sleep disturbances, anywhere between 50 to 80% prevalence, particularly insomnia and maintaining sleep throughout the night. There is evidence of shortened REM cycles in these children, along with a delayed deep sleep, which contributes to irregular sleep-wake patterns and daytime sleepiness. Sleep disorders, such as parasomnias, PLMs, and SDB, are also common in children with ASD. Decreased muscle tone, which is also common among children with significant ASD, which may contribute to apnea during REM sleep, when there is already a partial muscle paralysis. Anxiety. Children with generalized anxiety disorders experience high rates of insomnia. Struggling to regulate high arousal negative emotions makes sleep onset challenging and often impacts the entire family's sleep quality. Approximately 90% of children with GAD have high levels of bedtime fears or worries, difficulty sleeping alone or in a dark room, shorter sleep duration during the night, increased morning anxiety, and greater daytime sleepiness. Poor sleep quality may contribute to persistent or exacerbated symptoms of daytime anxiety and school or social difficulties. ADHD or attention deficit hyperactivity disorder. Children with ADHD commonly have comorbid sleep conditions, including behavioral insomnia, SDB, and RLS. Current guidelines recommend careful assessment of sleep quality and environmental conditions before conducting ADHD evaluation and/or initiating medications. Many ADHD symptoms resemble those of sleep-deprived children and children with untreated sleep apnea and RLS. Further, insufficient sleep in children without neurologic disorders all can mimic symptoms of ADHD. Sleep difficulties among children with ADHD are thought to be related to shared neurobiologic pathways involving areas of the cortex responsible for regulation and arousal, the medication effects of stimulants used, and the presence of comorbid mental health disorders. An example of which is methylphenidate formulations are first-line stimulant medications used to treat ADHD, but insomnia is the significant side effect. ADHD treatment guidelines recommend starting medications with low doses and titrating slowly to the lowest dose that results in improved outcomes and has the fewest side effects, with the intention that children and family continue long-term treatment. ADHD treatment guidelines emphasize the benefits of sleep hygiene education that involves parent-child participation and integrates cognitive behavioral interventions, positive reinforcement, and the use of environmental characteristics that promote and sustain sleep, specifically for children with ADHD taking stimulant medications. As children with ADHD mature, non-stimulant medications are often considered for management of ADHD and to promote sleep. Again, our additional resources here are the AASM Sleep Education for Teens, the CDC Sleep and Sleep Disorders, the Sleep Foundation Children and Sleep, and lastly, Health Children Sleep. We'll also take a brief glance over all the references, and that will conclude our day here for today. As always, I thank you for listening, and I see you at the next chapter. Take care, and goodbye.